स्वागत है। आज 321वें लेक्चर में हम आपके सामने आज उपस्थित हुए हैं। आज बहुत ही महत्वपूर्ण दिन है, गुरु पूर्णिमा के जन्म जयंती की आप सभी को बहुत-बहुत हार्दिक शुभकामनाएं। और इसके साथ-साथ हम एक और व्यक्ति के बारे में भी आज जानेंगे। सबसे पहले जो आज़ादी के उन वॉरियर्स को कहीं न कहीं जाना पहचाना जाना चाहिए था, जो कहीं न कहीं हमसे छूट गए, मगर उन्होंने अपने जीवन में बहुत अल्प समय में भी बहुत बढ़िया काम किया। तो इन सारी बातों को देखते हुए अभी बिरसा मुंडा एक महान व्यक्तित्व के बारे में आप सभी ने सुना होगा और उनको जाना भी होगा। तो उनके बारे में मैं 2 लाइन आपसे कहना चाहूँगी कि जो आदिवासियों की जल, जमीन और जंगल के लिए धरती बाबा का रूप लेके और बहुत अल्प आयु में, सिर्फ 25 वर्ष की आयु में उन्होंने इस धरती माँ को आज़ाद करवाने के लिए बहुत अच्छा संग्राम लड़ा और उन्होंने अपने जीवन का बलिदान दे दिया, वो वीर गति को प्राप्त हो गए। ऐसे बिरसा मुंडा जी, जिनको भगवान बिरसा मुंडा भी कहते हैं, उनके कार्य के कारण, जो आदिवासियों के लिए उनकी लगन थी, न्यायप्रियता थी, सत्यता थी, उनके लिए उन्होंने अपना जीवन कुर्बान कर दिया, उनके लिए वो शहीद हो गए। तो ऐसे ही बिरसा मुंडा जी के उस पे आप सबको शायद पता ना हो कि 15 नवंबर 2000 में बिहार से वो राज्य अलग हुआ, आप सभी जानते हैं। तो वो राज्य के अंदर उनका जन्म हुआ था। आज उनके नाम पे वहाँ का रांची का एयरपोर्ट बिरसा मुंडा एयरपोर्ट के नाम से जाना जाता है और आप सबको बहुत अच्छा लगा कि एक श्रद्धांजलि के रूप में सेंट्रल हॉल ऑफ द इंडियन पार्लियामेंट में आज उनकी छवि भी, पोर्ट्रेट भी लगा हुआ है। तो ये हमारे लिए उनके बलिदान के स्वरूप आज हम उनको याद करते हैं, क्योंकि उन्होंने आदिवासी संस्कृति, स्वायत्तता, स्वतंत्रता का एक बहुत अद्वितीय संग्राम लड़ा, आदिवासियों को एकत्र किया और जमींदारी के लिए और जंगल के ऊपर उनका एकाधिकार नहीं है,
राघु
इनके ऊपर वो निपटे थे,
हमें वाह
जो नहीं हो पाया, जिसके कारण उनको ये आदिवासियों के लिए ये लड़ाई संग्राम लड़ना पड़ा। इसके लिए वंदे मातरम जैसे हम समझते हैं कि बहुत बड़ा राष्ट्र को प्रतिबिंबित करने वाला शब्द है, ऐसे ही तब उन्होंने उल गुलान यानी प्रचंड विद्रोह एक नारा दिया और उसके लिए उस पूर्ण क्रांति के तहत उन्होंने सारे आदिवासियों को एक जगह पे इकट्ठा किया और उन्होंने ब्रिटिशर्स को जहां तक उनसे हो सका उन्होंने उसका प्रतिरोध करके, उनका प्रतिकार करके आदिवासियों को अपने मूलभूत अधिकार के लिए जागृत किया। तो ऐसे व्यक्ति के लिए आज हम, क्योंकि आज 19 नवंबर है और 15 नवंबर 1875 में उनका जन्म दिन है और अभी उन्हीं दिन के दौरान अभी हम उनको बहुत सारे राज्यों में भी उनको याद किया गया। आज हम भी उनको भावपूर्ण श्रद्धांजलि देते हैं कि उनके कर्मों से भारत आज भी दैदीप्यमान है और हम उनको आज भी याद करते हैं कि जो उन्होंने हमारे लिए, हमारे अच्छे आज के लिए अपने जीवन का बलिदान बहुत कम उम्र में, है ना, यानी 25 वर्ष की उम्र में ही कर दिया। 9 जून 1900 में उनका बलिदान हो गया। वो भी किसी उनके परिचित ने ही 500 रुपये के लिए उनकी खबर सरकार तक पहुंचा दी, ब्रिटिशर्स तक पहुंचा दी और उनका वहां गिरफ्तारी हो गई और उनको स्लो पॉइजन देके, बहुत बलिष्ठ थे और साहसी थे, निडर थे, उसके बावजूद भी 25 वर्ष की आयु में कारावास में उनको लगातार जहर देने के कारण, स्लो पॉइजनिंग देने के कारण उनकी स्वास्थ्य खराब रहने के कारण उनकी मृत्यु हो गई। तो आज हम उनके बलिदान को नतमस्तक रहते हुए उनको याद करते हैं और हम उनके सपनों का भारत बनाने के लिए जरूर एक बार बढ़िया सी कोशिश करेंगे कि जिससे उनका बलिदान व्यर्थ ना हो जाए और भारत में सभी लोग समान रूप से आजीविका प्राप्त करके यहाँ रह सके। तो उन्होंने इसी तरीके से अबुआ दिशुम अबुआ राज, यानी हमारा देश हमारा राज, ऐसी भी एक बहुत अच्छी उक्ति आदिवासियों के बीच में प्रचलित की थी। और वो कहीं ना कहीं आज के समय में भी प्रासंगिक है कि हम ग्राम पंचायत की बात करते हैं तो उन्हीं बात का कहीं ना कहीं घोष होता है। तो ऐसे महान व्यक्ति के व्यक्तित्व को प्रणाम करते हुए मैं आज के व्याख्यान की शुरुआत करती हूँ। 321 के व्याख्यान के लिए आज के कोऑर्डिनेटर के रूप में मैं डॉक्टर ममता, जो राष्ट्रीय आयुर्वेद संस्थान में बाल रोग विभाग में अध्येत्री है, उनको मैं आमंत्रित करती हूँ। आप इससे पूर्व सीकर में आयुर्वेदिक मेडिकल ऑफिसर के पद पर कार्यरत थी। वर्तमान समय में आप राष्ट्रीय आयुर्वेद संस्थान में अध्येत्री के रूप में बाल रोग विभाग में अभी आप अध्ययन कर रही है। ओवर टू यू
थैंक यू
डॉक्टर
मैम।
ममता।
नमस्कार सभी को। कार्तिक पूर्णिमा, गुरु नानक देव जयंती की सभी को हार्दिक बधाइयाँ एवं समस्त आयुर्वेद अनुरागियों एवं भारतवर्ष के लिए मंगल कामनाएं। नाउ वी स्टार्ट इंट्रोडक्शन ऑफ ड्रग फ्रॉम वैद्य अनुभा मैम, मेडिकल ऑफिसर इन स्टेट गवर्नमेंट ऑफ यूपी। Her BMS from SKDR Ayurvedic College, Muzaffarnagar, UP. MD and PhD, National Institute of Ayurveda, Jaipur, Rajasthan. She also completed other professional course in Ayurveda, cosmetology and Ayurvedic diet and nutrition from NIA, Jaipur. Her book publication, Species for Health. She actively participates as expert in Rasoi Se program, Doordarshan, Rajasthan. Over to ma'am. Anubha ma'am, please.
Good afternoon, ma'am. Good afternoon, sir. And good afternoon to all the fellow listeners of Ayurveda. आज का जो हमारा ड्रग है वो है नटमेग और मेस, यानी कि जावित्री और जातिफल। सबसे पहले तो ये कि इन दोनों में एक कंफ्यूजन रहता है, क्योंकि ये सेम प्लांट की ड्रग है, तो कौन सी ड्रग, इनमें से कौन जो ड्रग है वो क्या पार्ट है प्लांट का। तो जो जातिफल है वो सीड कर्नेल है, यानी कि बीज के अंदर से जो मींगी निकलती है वो जातिफल है, जिसको हम जायफल बोलते हैं। और जावित्री जो है वो बीज के ऊपर एक आवरण जैसा रहता है, एक कवरिंग रहती है, वो जो कवरिंग है उसको जावित्री बोला जाता है। दोनों में डिफरेंस क्या है कि जो मतलब क्वालिटीज में या इनकी प्रॉपर्टीज और एक्शंस में जो डिफरेंस है वो मेन ये है कि जो जावित्री है वो उससे ज्यादा कम तीक्ष्ण होती है। मतलब जायफल जो है वो ज्यादा तीक्ष्ण है और जावित्री जो है वो उसमें भी सेम गुण कर्म मिलते हैं, लेकिन थोड़े से अल्प मात्रा में मिलते हैं। और इसीलिए जहाँ पे हमें मृदु रूप में यूज करना है तो हम वहाँ जावित्री का यूज करते हैं, अदरवाइज जायफल का यूज किया जाता है। बोटेनिकल सोर्स जो है दोनों दोनों का माइरिस्टिका फ्रेग्रेंस ही है। अब बात करते हैं इनके जो शास्त्रीय प्रयोग हैं, अगर उनके बारे में हम बात करें तो जो सबसे मेन प्रयोग जो आता है वो जातिफल या जातिफल का वो आता है कि डायरिया में, यानी डायरिया में। तो इसका अगर हम पाउडर लेते हैं, पाउडर इनटेक भी जो किया जाता है वो डायरिया के लिए किया जाता है। दूसरा, क्योंकि मेरा कॉस्मेटोलॉजी से ज्यादा संबंध है, तो जो फ्रिकल्स हैं, व्यंग हैं, व्यंग में इसका पेस्ट का लोकल एप्लीकेशन जो है वो बहुत अच्छा रिजल्ट देता है। दूसरा, इसका स्किन डिजीजेस में विपादिका में बहुत अच्छा एक्सटर्नल एप्लीकेशन आता है। अगर हम इसको घृत और मधु के साथ एक्सटर्नल एप्लीकेशन करते हैं तो सर्जरस के कंपैरेबल इसके रिजल्ट्स आपको मिलते हैं, और उस कहीं कहीं पे उससे बेटर भी आपको इसके रिजल्ट्स मिलते हैं। दूसरा, इसका जो यूज है वो यूज होता है थर्स्ट में। अगर एक्सेसिव थर्स्ट है, तृष्णा, अत्यधिक तृष्णा है, तब भी हम इसका यूज करते हैं। दूसरा, जो वॉमिटिंग है, जो जैसे बहुत सारे लोगों को जो ये मोशन सिकनेस होती है, मोशन सिकनेस में इसके चूर्ण को घृत के साथ लेने से उसमें बहुत अच्छा रिजल्ट मिलता है। दूसरा, इसका जो रिजल्ट है, क्योंकि इसके अंदर अगर हम केमिकली देखें तो वॉलेटाइल ऑयल प्रेजेंट रहता है, जिसमें माइरिस्टिक एसिड, ट्राइमाइरोसिटिन और यूजिनॉल, पीसाइनिन, इस तरह के कंपाउंड्स रहते हैं। तो बेसिकली यूजिनॉन की वजह से इसका रिप्रोडक्टिव सिस्टम पर बहुत अच्छा रिजल्ट आता है। रिप्रोडक्टिव सिस्टम में अगर मेल की बात करें तो स्पर्मेटोरिया जो है उसके अंदर इसका रिजल्ट बहुत अच्छा मिलता है, और फीमेल्स में अत्यार्तव में इसका रिजल्ट बहुत अच्छा मिलता है। अब वैसे प्रशस्त जो है, जो ज्यादातर संहिताओं में हमारे यहाँ मिलता है, वो डायरिया में इसका सबसे ज्यादा यूज मिलता है। अब अगर हम इसके मतलब ये तो शास्त्रीय पक्ष हुआ, अगर हम ये देखें कि फार्माकोलॉजिकली या मॉडर्न एविडेंसेस क्या हैं इसके लिए, तो इसके अंदर लाइगेंस लिग्नेंस करके एक कंपाउंड की पूरी कैटेगरी होती है। उसमें से अलग अलग लिग्नेंस मिलते हैं, जिसमें से मेन है इराइथ्रो ऑस्ट्रेलियोलाइगेन 6, EA6 भी बोलते हैं उसको। बेसिकली बहुत ही पोटेंट एंटी फंगल ड्रग है। इवन कैंडिडा एल्बिकेंस जो है उसके खिलाफ भी इसके बहुत अच्छे रिजल्ट्स हैं, कंपैरेबल टू कीटोकोनाजोल और बाकी के जो एंटी फंगल ड्रग्स हैं उनके कंपैरेबल इसके रिजल्ट्स मिलते हैं। दूसरा, इसके अंदर तीन ऐसे कंपाउंड्स मिलते हैं जैसे रेसोसिनोल्स, मेलाबेरेसिन बी। ये जो कंपाउंड्स हैं ये बहुत ही अच्छे एंटीबैक्टीरियल हैं, और खास करके इनका जो रिजल्ट है वो हमें मिलता है जो अपने अनारोबिक बैक्टीरियाज होते हैं उसके ऊपर। फिर इसके अंदर डाइहाइड्रो ग्वेरेटिक एसिड मिलता है, जिसके रिजल्ट्स मिलते हैं इसके ये जो हमारे एच पाइलोरी, जो कि ये जो हमारे अल्सर्स हैं उसका एक पॉजिटिव फैक्टर है, उसमें उसका रिजल्ट बहुत अच्छा प्रूव हुआ है। तो इस तरीके से, क्योंकि हमारे आचार्यों ने भी इसको विसूचिका के लिए भी बताया गया है, तो इस तरीके से इसका रोल हमें मिलता है। दूसरा, इसके अंदर सुगंधी गुण है। सुगंधी गुण जो है वो अगर शास्त्र के हिसाब से देखें तो ये पित्त का शमन करने वाला होता है, और इसको कहीं कहीं पे जो है नाड़ी बल्य भी कहा गया है। तो अगर हम उसके इस हिसाब से देखें तो ट्राइमाइरोसिटिन इसके अंदर मिलता है, और ट्राइमाइरोसिटिन जो होता है उसके अंदर न्यूरोप्रोटेक्टिव एक्टिविटी मिलती है। तो यहाँ पे भी इसका एक शास्त्रीय पक्ष जो है वो प्रूव होता है। और ये तो थे शॉर्ट में इसके कुछ शास्त्रीय पक्ष, और जो इसकी कुछ फार्माकोलॉजिकल एक्टिविटीज हैं जो उन शास्त्रीय कर्मों को प्रूव करती हैं उनके बारे में। अगर हम बात करें एडल्ट्रेशन की, तो इसके अंदर एडल्ट्रेशन भी मिलता है। एडल्ट्रेशन इसी प्लांट का, इसी स्पीशी, इसी जीनस का दूसरा प्लांट होता है माइरिस्टिका मेलाबराइका। ये माइरिस्टिका फ्रेग्रेंस है, वो माइरिस्टिका मेलाबराइका नाम से आता है, जिसको बॉम्बे जायफल भी बोलते हैं, बम्बई की जायफल भी बोलते हैं। उसका इसके अंदर एडल्ट्रेशन किया जाता है। पहचानेंगे कैसे? बहुत सिंपल सी पहचान है कि जो जायफल होता है, जो असली जायफल है, वो ऑलमोस्ट सर्कुलर होता है, ऑलमोस्ट। और जो एडल्ट्रेटेड है वो लंबाई में ज्यादा होता है, ऑलमोस्ट रेक्टेंगुलर शेप का आपको मिलेगा। तो उससे इसकी बहुत अच्छे से आप इसकी पहचान कर सकते हैं। थैंक यू सो मच। दिस वाज अ शॉर्ट डिस्क्रिप्शन अबाउट जातिफल एंड जावित्री। थैंक यू।
थैंक यू मैम, आपने बहुत अच्छी तरीके से जावित्री जायफल में अंतर बताया और सामान्य इसके उपयोग बताए। अब मैं आज के वक्ता डॉक्टर रेस्पेक्टेड डॉक्टर श्रीनिधि कुमार आचार्य सर से निवेदन करूंगी कि वो अपना एक्सपीरियंस शेयर करें, क्लिनिकल अंडरस्टैंडिंग एंड केस स्टडी ऑफ एनीमिया इन चिल्ड्रन। इसके साथ ही मैं सर का ब्रीफ इंट्रोडक्शन देना चाहूंगी। सर जो है अभी MD PhD हैं, कौमारव्रत विभाग में एसोसिएट प्रोफेसर के पद पे कार्यरत हैं, नेशनल इंस्टीट्यूट ऑफ आयुर्वेदा, डीम्ड टू बी यूनिवर्सिटी जयपुर में। He is native of Mangalore district of Karnataka and completed his undergraduation in Ayurveda from SDM College of Ayurveda, Udupi. Sir जो है later he pursued his postgraduate degree from IMS Banaras Hindu University in 2003. He also completed his PhD from Rajasthan Ayurveda University Jodhpur in year 2011. He has got a 10-year teaching experience of both undergraduate and postgraduate of Ayurveda. He served as assistant professor and reader in Department of PG Study in Komarbrate, SDM College and Hospital of Ayurveda, Tanir Allah Hassan. For more than 6 years and active in many successful health programs launched by government. Since last 12 years, he is re-entering his service at Department of PG Studies in Komarbrate National Institute of Ayurveda, Jaipur. He is also involved research activity in Ayurveda since last 18 years and guided more than 20 research papers at postgraduate and PhD level. He is recognized guide for PG and PhD. He is also extended his service as examiner, paper setters, member of inspection committee, etc. at different university and delivered more than 30 guest lectures at national, international seminars, CME and workshops. He has the credit of publishing more than 40 research articles in various international, national and peer-reviewed journals. He authored the textbook of Kumar Bhate titled Acharya's Textbook of Kumar Bhate in 2 volumes, get published from Chokhamba Oriental, Varanasi. He is actively involved in clinical and patient care activity as a consultant Ayurveda pediatrician. He is also involved Ayurveda awareness program and his programs were telecasted in Doordarshan, ETV, radio, etc. Sir has a great knowledge and personality in field of Kumar Bhate. Sir has great experience in clinical understanding and their Ayurvedic management. Please, sir, give and share your clinical understanding. Over to sir. Sir, please.
Hello. Hello, am I audible there?
Yes, sir.
Okay, please give me the option to share the slides.
हाँ जी डॉक्टर साहब जी. सर ये प्रेजेंट नाउ का जो साइन है ना वहां से कर पाएंगे सर आप?
मैं कर रहा हूँ मैडम, बट
अच्छा, हो नहीं रहा.
शायद कोई कमांड आपकी तरफ से देना पड़ेगा शायद.
अच्छा ठीक है, मैं आईटी वाले भैया को पूछती हूँ, 1 मिनट. तभी तक शुरू कर दीजिए, कुछ बोलना मैं उसको कहती हूँ, है ना जी.
ठीक है. Screen is visible there now?
नहीं सर, अभी तो नहीं आई सर.
Hello.
जी सर.
शेयर टैब ऐसा कुछ वहां से आना चाहिए, तभी तो मैं शेयर कर पाऊंगा.
जी सर, मैं कहती हूँ, उसको कह रही हूँ सर. सर वो भैया ऐसे कह रहे हैं कि आप पहले पीपीटी नीचे ओपन कर लीजिए, फिर वो नीचे से हो जाएगा सर, ऐसे कह रहे हैं.
पीपीटी तो मैंने ओपन कर लिया.
पीपीटी ओपन करके फिर प्रेजेंट नाउ पर क्लिक करें तो हो जाएगा,
पीपीटी ओपन कर
ऐसा बता रहे हैं.
प्रेजेंट नाउ का.
जी सर.
पीपीटी तो मैंने ओपन किया है.
हाँ, पीपीटी ओपन करके अगर रह जाती है ना तो फिर प्रेजेंट नाउ पर क्लिक करके फिर नीचे से वो जब करेंगे ना तो हो जाएगा सर। या सर मुझे ईमेल कर दीजिए, मैं करती हूँ शेयर सर। मैं आपको
प्रेजेंट
मेल मेल करती
प्रेजेंट
हूँ वो
नाउ वाला
ईमेल।
कोई
जी
प्रेजेंट
सर।
नाउ वाला कोई ऑप्शन ही नहीं आ रहा है।
सर पता नहीं।
अभी तो आ रहा है क्या? स्लाइड्स नहीं है ना?
नहीं सर, अभी तो नहीं आई है, डिस्प्ले नहीं हुआ सर।
पीपीटी तो ओपन कर लिया, इसमें प्रेजेंट में ऑप्शन हो जाएगा।
सर आपका दूसरा कोई नंबर है जिसके ऊपर वो आईटी वाले भैया आपको फोन कर सके, तो ऐसा कुछ करें सर।
मेरा नंबर 80059। हेलो।
हाँ जी सर।
80059।
सर मैं इसमें चैट बॉक्स में लिख देती हूँ, 1 मिनट, या मैं उसमें व्हाट्सएप में लिखती हूँ, 1 मिनट सर। 8। जी सर। जी सर, 800।
59।
जी। जी सर।
35409।
35409। जी सर, वो अभी आपको कॉल करेंगे सर। जी सर, 1 मिनट।
कॉल करते हैं। हेलो। हेलो। हाँ
जी
सर
सर,
बोलिए।
आवाज है।
हाँ सर बोलिए। नहीं, आपका वॉइस ठीक से नहीं आ रहा। हेलो। हाँ सर बोलिए। हाँ बोलिए।
जैसा कि आप सभी जानते हो, सर का जो एक्सपीरियंस है क्लिनिकल अंडरस्टैंडिंग में बहुत ही अच्छा है। सर के बहुत सारे पेशेंट नेफ्रोटिक सिंड्रोम, डायबिटीज फर्स्ट और सेरेब्रल पाल्सी और भी बहुत सारे पेशेंट जो अंडर ट्रायल चल रहे हैं, उनका बहुत अच्छा रिजल्ट चल रहा है। तो डेफिनेटली सर उनमें बहुत ही महंगा या कॉस्टली या बाहर का ट्रीटमेंट नहीं लिखते हैं। सर जो दवाएं लिखते हैं वो क्लासिक्स में अपने जो मेंशन रहती है उनमें एक आयुर्वेदिक कॉन्सेप्ट लगा के सर ट्रीटमेंट लिखते हैं। हेलो सर।
ममता, कुछ ही तुम केस शेयर कर दो, सर है ना वो कोशिश कर रहे हैं, तो आप कुछ बाल रोग विभाग में कुछ इंटरेस्टिंग केस हो तब तक एक आधा बता दो।
जी मैम। एक केस अनाउंस कर रही हूँ. A 10-month-old infant has poor weight gain and persistent cough and history of several bouts of pneumonia. The mother described the child as having very large foul-smelling stool for months. Which of the following is diagnostic? Manure is likely to result the correct diagnosis of the child. इसके लिए CT of the chest, serum immunoglobulin, TB, skin test, sweet chloride test. The test is clearly indicate cystic fibrosis. आंसर है इसका. तो cystic fibrosis is a complex chronic disease that primarily affect the lungs and digestive system. People with cystic fibrosis inherit 2 copies of chromosome number 7. इसमें क्या होता है? कफिंग एंड विजिंग विथ फ्लीगम अपने को देखने को मिलता है. हैविंग लॉट ऑफ म्यूकस इन लंग्स, रिकरेंट लंग इन्फेक्शन सच एज निमोनिया, ब्रोंकाइटिस एक्सेट्रा, शॉर्टनेस ऑफ ब्रीथ.
डॉक्टर ममता सर की पीपीटी
जी जी सर. और तो मैं इसके लिए बताना चाहूंगी स्वीट क्लोराइड टेस्ट एंड जेनेटिक या कैरियर टेस्ट करवाते हैं. ओवर टू सर प्लीज. सर आपका म्यूट है, प्लीज अनम्यूट कीजिएगा.
अभी स्लाइड शो हो रहा है ना?
हाँ जी सर. जी सर.
ठीक है. मेरा आवाज भी आ रहा है?
मेरा आवाज भी लाउड एंड क्लियर.
जी.
Okay, thank you very much for giving me this opportunity, and for the organizers, I thank from my bottom of the heart. Sorry for the inconvenience caused because of technical problems. So, if Dr. Hetal Madam permit, I will start.
जी सर बिल्कुल. धन्यवाद सर. जी सर.
Okay. So now the topic is clinical case studies and as well as understanding of anemia in children, and we will see the case scenarios and also clinical understanding one by one. So in the beginning we will have some of the basics. The basics is what is anemia. Anemia is that condition, as all of us know, that this is a condition where deoxyhemoglobin will going to raise in the blood. If the amount of deoxyhemoglobin is more than some 7 grams and all, then we will technically or clinically call it as anemia. This everybody knows. Now, every cell and metabolic activity of the body will be affected if there is anemia. We know that anemia means there is less RBCs. Once the less RBCs are there, the oxygen carriage capacity will go decrease, and each cell is receiving less oxygen. When each cell is receiving less oxygen, naturally the oxygen is very much important for all metabolic activities, and metabolic function, metabolic activity of each and every cell will go down. This is the reason why in anemia we will have fatigue. Okay, fatigue, easy fatigability is one of the most common symptom of anemia because of this reason only. Meantime, when the metabolism and activity of the nerve cells are get affected, that leads to a symptom called as irritability. So irritability and as well as loss of concentration, these are the two basic clinical presentations of anemia. So it left to the physician that whether he will identify this symptom at the early or he will identify it at the end. But these symptoms will be there in the beginning itself. Now, low hemoglobin affect almost all the tissues, cells of the body, and fatigue and irritability. Fatigue and irritability. So now, this is what I told. Now, RBC is produced from the bone marrow of the long bones and as well as flat bones. This fact also we know. But what is more important to understand is the process of formation of RBC. When we have process of formation of RBC, basically it forms from the stem cells which are present in the bone cells or bone marrow cells.
डॉक्टर साहब
Hello.
सॉरी डॉक्टर साहब, वो स्लाइड आगे नहीं हो रही है, वो सेम स्लाइड ही है, पहली स्लाइड ही।
अच्छा,
अभी आप कर रहे थे स्लाइड, एक्चुअली मैं सोच रही थी कि थोड़ी देर में ही पूछूं, शायद मैंने कहा इंट्रोडक्शन ही हो।
सो अभी भी हेडिंग में ही है।
हाँ सर, हेडिंग में ही है, आपका नाम और क्लिनिकल केस स्टडी वाला जो हेडिंग है वही आ रहा है सर।
स्लाइड होता है।
जी सर, अब चेंज हुई है सर, अब हाँ जी सर।
अब चेंज हुआ
सर, अभी डिसअपियर हो गई, अभी चेंज तो हुई थी सर।
एक मिनट।
जी सर।
सो आई थिंक नाउ इट इज विजिबल।
जी सर, नाउ विजिबल।
This is the previous slide. This is also visible.
जी सर,
Yes,
विजिबल।
sir.
Okay, so it will go like this. Okay, so very important to know about the formation of the RBCs. A formation of the RBCs is basically from what you say, from the bone marrows, and from the bone marrow when it is formed, so it has different process. In the beginning, it forms as erythrocyte. This erythrocytes is basically a cell which has got large volume and a large size, and as well as it got a nucleus. And as the maturation takes place, this erythrocytes get converted into early normoblast, and early normoblast is get converted into intermediate normoblast. From the intermediate normoblast, it is converted into late normoblast. From the late normoblast, this is converted into reticulocyte, and from the reticulocyte, there will be mature RBC. So this is a process of formation of a RBC. So in the beginning, it forms as erythrocyte, and this erythrocyte has got large size and as well as nucleus. But as the maturation takes place, the size of the RBC gradually comes down, and nucleus which is present in the RBC will disappear, and this will be replaced by hemoglobin. This is a long process. Okay, at the last, when the reticulocytes are get released into the blood, and these reticulocytes are having very short half-life, and they are immediately get converted into RBCs. In this RBC which is there, so these RBCs are having the small size of 7 microns, and they carry on the function. So what I mean to say is, in the process of development of RBC, always what happens? A large cell becomes a small cell, and it reaches the size of 7 micron. Now, this is one of the specialty of RBC. We'll call it as right shift in physiology. Okay. So anyway, this is one important factor that we should know. So if you are releasing, your body bone marrow is releasing a larger size of RBCs, maybe the early normoblast or late normoblast or intermediate normoblast, and that cell is called as macrocyte. That cell is called as macrocyte. Okay, if it is releasing a RBC without introduction of hemoglobin inside it, then it leads to hypochromic anemia, so hypochromic conditions that we will see later. So this is a important thing in the development of and maturation of the RBCs. Now, in the first cell which comes to the circulation from the bone marrow, from the RBC stem cells, is reticulocyte, which has got very less half-life, and immediately it becomes RBC in the blood. Now, the bone marrow is always in a hurry when there is a need like hemolysis. When there is hemolysis taking place, that means suppose due to any of the conditions, if the RBC destruction in the blood is more, then bone marrow will be more and more active, and it produces more and more RBCs. Okay, so if the hemolysis is more, then the hemolysis is also carried out by an important organ which is called a spleen. So on doing hemolysis, the spleen will be get hypertrophied, and this leads to splenomegaly. So increased hemolysis always leads to splenomegaly, and if the splenomegaly is also exhausted by doing that, then this function will be taken by the liver and later by the reticuloendothelial system. These are some of the basic things that we should know about the anemia. Now we'll go to the next slide. I think slide is changed now.
सर, अभी बेसिक एनीमिया 4th स्लाइड डिस्प्ले हो रही है, 4th
नहीं, उसमें क्या लिखा है?
आ रही है
सर, बेसिक एनीमिया when we say pallor and what is.
Yes. Okay, it's okay. So we are talking about basics of anemia. When we say pallor, okay, usually we know that anemia is identified by means of pallor. Everybody knows that. child is looking painful, the child is having anemia. And when we say pallor, now what are the possibilities? When we say the pallor, what are the different possibilities? Every time when there is a pallor, it is not suggestive of anemia. There is some disturbance. Please correct it.
Dr. Patil Anu, please mute your mic. Dr. Patil Anu. Hello. Dr. Patil. Dr. Patil, please mute your mic.
When we say pallor, every time pallor does not suggest that there is anemia. You may have the pallor in different situation. Of course, I agree. Anemia is one of the major situations when you will find the pallor. Apart from that, you also have got some condition, for example, poor circulation. If there is simply poor circulation of the blood is there, then also there will be pallor. Okay. If the child is having hypothermia, the circulation will be less to the peripheral parts of the body. That also leads to pallor. Okay. Or in the acute condition of the stress, you will have pallor. When you are facing the viva and some unexpected question comes to you and you are totally blank and your total face turns pale, it is because of the stress. Acute stress conditions also leads to paleness. And any condition where there is sudden peripheral vasoconstriction, as occurs in case of fever, there is also paleness. Okay, or conditions of the shock, there is also paleness or pallor. Or in some conditions like nephrotic syndrome, we will have call it as waxy pallor. What do you mean by waxy pallor? Waxy pallor means on superficial appearance you don't have any pallor, but if you stretch the skin, then you will see the pallor. This condition is called as waxy pallor. Okay, this is commonly seen in nephrotic syndrome. What I mean to say is, any condition which is having pallor is not because of anemia. Of course, although anemia is a major cause, we have got so many other conditions where, irrespective of anemia, we will have the pallor. These are some of the list. But what is the difference? The difference is, in all these conditions, the pallor is very transient. If it is due to stress, it is transient. Hypothermia, it is transient. After a few hours, it will go down. Okay. Or if you provide some warm environment to the child, the pallor disappears. But if the pallor is because of a hemopoietic system, pallor is because of the RBC problem or bone marrow problem or a deficiency problem or iron problem, the pallor is not transient and it is not waxing and waning type, and pallor is continuous, stable, or it is progressive. So this is how we have to difference, because every pallor, when you look at the patient, every pallor is not anemia. There are so many conditions which can cause pallor-like situation apart from anemia. This is what I mean to clear now. Now we will look into the pallor examination. See, this is very important. Always we look into the conjunctiva, we know that. But how exactly to see the pallor? How exactly we are going to see it? Number one is, you have to look at the bulbar conjunctiva. There are two types of conjunctivas are there. One is palpebral conjunctiva, another is bulbar conjunctiva. Okay, so always you have to look into bulbar conjunctiva where, because we know that sclera is a avascular structure, there is no circulation. So there is no need of looking at pallor at the sclera portion. So we have to look at the bulbar conjunctiva. Number two is compare with the normal palm. I will show the pictures. You have to always compare your palm with the patient palm and you have to see the difference. Okay. Number three, that you have to also see what you mean the palmar crease. In the palm you will have palmar crease, and you have to also look into palmar crease for the examination of the pallor, and you have to also look at the tip of the tongue. So these are the 3 or 4 important sites that you have to see when you are doubting about pallor. Number one is you have to see at the conjunctiva, then you have to compare your palm with the patient's palm, and then you have to see the tongue, then you have to also look into the palmar crease. So see, these are the pictures. This is how, see, this is a patient palm and this is a physician palm, and see the difference of a paleness. Okay, and this is the area where exactly you have to see in the conjunctiva, not in this particular area, sclera. Sclera is not a vascular part. Okay, exactly in this particular bulbar conjunctiva also, where you have to see is this particular ridge. Okay, see, most of the time this particular ridge of the eyelid. So this looks very, very pale. Brim, we will call it as brim of the eyelid. So that is looks very pale. And in the tongue, if you want to see, this is a tongue with no pallor, and this is a tongue with a pallor, and this is a tongue with severe pallor. So these three identifications should be very, very clear. Just by looking at that, you can identify that whether this particular pallor is mild, moderate, or severe. Just like in this case, this is the moderate one, and this is the severe one. Now, when I will say about pallor will be two conditions will be there. In the clinically, you will get two conditions. One is pallor will be there with jaundice. Another one is pallor will be there without jaundice. See, simple things. We will discuss some of the simple aspects in the clinical scenario. Okay, so what do you mean? When only pallor is there, there is no jaundice. So it's very simple. When there is no jaundice, it suggests that this particular pallor is not because of over destruction of the RBCs. Because if there is over destruction of the RBCs, so then heme metabolism will take place. Heme will come out. Heme will undergo the metabolism, and iron will undergo metabolism. As a result, there is formation of biliverdin. Biliverdin is converted into bilirubin, and as a result, there is formation of the jaundice. Suppose any condition where there is no jaundice, there is only pallor, it clearly suggests that the pathology is not related to the hemolytic pathology. RBCs are not destroyed. RBCs are not over destroyed. Okay, but there is some problem with the formation of the RBC itself. Therefore, pallor is there. Okay, so deficiency anemia or bone marrow anemia or some hemorrhagic problems will present with only pallor. There is no jaundice. There is no jaundice. Only pallor will be there. So immediately we have to think that so this is not any hemolytic anemia. Hemolysis is not taking place. If there is a hemolytic, hemolysis is going on, definitely there should be jaundice. Okay, so when this you have to understand. Similarly, another condition where pallor is there along with the jaundice. Pallor is there along with the jaundice, so it clearly suggests that there is over destruction of the RBCs. Therefore, bilirubin is formed, and this is definitely some of the hemolytic pathology. RBCs are destroyed before their age, or RBCs are over destroyed. Now we'll talk about different types of anemia. See, clinically, there may be so many types of anemia. There may be so many causes of anemia. But clinically, what is important for us is only four. That is, one is deficiency anemia, one is hemolytic anemia, another one is bone marrow problem anemia, and another one is hemorrhagic anemia. Hemorrhagic anemia. So these are the only four types of anemias that we have to always understand in the clinical scenario. And if you understand this very well, there is no issues with the anemia diagnosis and also anemia treatment. I hope I am audible to all.
जी sir.
Yes, sir.
Okay. So now how to identify these anemias, different types of anemias in the clinical scenario? Very simple. Now I will tell a story to you, and through this story I want to explain these four types of anemias to you. Now, one day, few days back, I went to a shop and I asked for a pen. Okay, that's a beautiful pen. I used to write by that pen only, and that was available in one particular shop. So I went there and asked the shopkeeper that I want that pen. Then shopkeeper told me, sir, there is no stock. And I was surprised. I asked why there is no stock, and he said, sir, factory is not producing such pens now. Okay, then I again asked why factory is not producing such a beautiful pen. It was having very good demand in the market. Why it is not producing? And he says, sir, I exactly don't know, but factory is, I think, on strike, or factory is not working now. Therefore, the pen is not coming to the market. Now, I was surprised, and next day I got the address of that factory and I visited that factory. Okay, I visited that factory, and when I go there and see the factory is running, but shopkeeper told that factory is not working or something like that. Then I called one person and asked, the factory is running, why pen is not reaching the shop? The market pen is not available, but your factory is working. So now what comes? It's a group of 4 people that I asked, why your pens are not coming? Then he told, among the 4 members, one member told, sir, factory is running, but our production is very poor and production is very less. Okay, that means they are not able to produce how much pens they actually want, so therefore there is shortage of pens. Another person told in that group, sir, factory is running, but this factory is now captured by some lobbies, and they appointed their own workers who are less efficient than the original workers. Okay, then I thought, okay, this may be the cause. And another person told, sir, factory is working, but these workers are not paid properly, so workers are get depressed. Therefore, they are not producing the pen. Therefore, the pen is not available in the market. Last person told, sir, factory is working, but this factory is only for the show. But inside the factory, instead of pen, some other materials are get stored. Okay, so this is the 4 answers given by the group of 4 people when I went there. So this is a typical situation of a bone marrow anemia. This bone marrow is nothing but the factory. This bone marrow is nothing but the factory. And when the bone marrow is not working properly, you will have anemia. There are 4 important causes why bone marrow will not work properly. The first person told factory is running, the production is very, very poor or very less. It suggests that the bone marrow is not able to produce good amount of the RBCs. Okay, this is a condition of bone marrow aplasia. There is a bone marrow aplasia because bone marrow stem cells are itself decreased. It's a condition of bone marrow aplasia. Most of the time it is hereditary in nature. Another person told factory is running, but it is captured by some of the lobbies. Some gundas, some rowdy people came and they captured, and they are now running their own lobby, and they appointed such workers who don't know how to they captured the place of the original workers. This is a condition of bone marrow infiltration. Bone marrow infiltration, when normal bone marrow cells are get replaced by some other cells which are very less efficient and cannot produce the RBCs, then it leads to anemia. Third person told, sir, factory is running, but they are not paid properly, they are depressed, how can they work? This is a condition of bone marrow depression. Bone marrow, everything is there. Bone marrow tissues are there, stem cells are there, but they are under the state of depression. This is called as bone marrow depression. This may be caused by some of the infections, or this may be because of some of the drugs, or so many other things. The last person told, sir, everything is there, but this factory is only for the show off, but something other than this is going on there. This is bone marrow storage disorders. Okay, that is bone marrows are get overlapped by some other materials which are not at all required. Okay, so this is called as bone marrow anemia. This is one of the commonest cause of anemia, bone marrow anemia. These are the 4 important causes. Now the question comes, then what happens? I met another group of people there. I went ahead and I met another group of people, but what they are telling is completely different story. So I asked them, why pen is not available? Then there's a, sir, what these people are telling is wrong. Actually the fact is, sir, sometimes the factory is running here, but product is not reaching to the site or a target site because there is no truck service. Okay, truck service means you don't have the trucks to carry the goods to the market. Yes. So another person told, sir, truck is there, but drivers are on strike. Drivers are not working properly. They are very irregular. They are not paid properly. Okay. Another person told, sir, driver and truck both are there, but when they are carrying these goods to the market, in between somebody come and they loot it. So in the market, the pen is not available. Now, when I see these 3 sentences told by them, it suggests that this is a hemolytic anemia. Hemolytic anemia means you have the RBCs of 120 days lifespan, but before the completion of 120 days itself, that RBCs has been destroyed. In this case, the factory is producing the RBCs, bone marrow factory is producing the RBCs, but before the completion of their lifespan itself, these RBCs are get destroyed or looted by some of the rowdies. Okay, now why they are happening? This can happen because of so many things. First, I told that there is a problem in truck service. Trucks are not able to carry the goods because, see, RBC size and shape problems. If there is a problem with the RBC size and shape, that RBC is not able to live for a long time because spleen will going to destroy it. That may be the one problem. The size and shape of the RBC is differing. Okay, it's abnormal. There may be some enzyme defect in the RBC membrane that is making, for example, G6PD deficiency. Okay, we have got many sickle cell disorders, sickle cell disease or spirocytosis, okay, even thalassemia. So we have got size and shape problems because of which the RBC has been destroyed earlier. And again, he says that the truck is the drivers are on strike. Maybe the drivers, that is circulation, may be stasis, there is slow circulation, that may lead to the stasis, and because of the stasis there is a clumping and RBCs are destroyed. This is also possible. And the last one says, sir, everything is fine, sir. So when you are taking the goods to the market, somebody will come in between and loot it. So how can we provide the product to the market? It is not possible. What is this? This is the typical, a mature RBC has been destroyed. Mature RBC has been destroyed before completion of its 120 days. This is typical of autoimmune hemolytic anemia. Okay, autoimmune hemolytic anemia. So this is a second group of anemias which clinically we have to see, hemolytic anemia, where RBCs are destroyed before completion of their lifespan. It may be because of RBC enzyme defect, RBC shape defect, size defect, or it may be because of some of the autoimmune antibodies which are going and attacking the RBCs. Okay, so now this is the second group of hemolytic anemia, that is called as hemolytic anemia. So when the RBCs are destroyed earlier, what actually you expect? Spleen is working more, because to clear that, spleen is working more. So then spleen has to work more. So naturally we will have splenomegaly. So always remember, hemolytic anemia, the characteristic features of hemolytic anemia is there will be splenomegaly, and if the spleen is exhausted, then the hepatomegaly will come. Then liver will take over the work. If it is also exhausted, then the reticuloendothelial system will take the work, and everything, all the lymph nodes, etc., will be enlarged. Anyway, this is the second type of anemia. Now the scenario is again changed. Then I directly go and met the factory owner. Sir, you tell me, these people are narrating the different stories. Actually, you tell me, sir, what exactly happened. Then factory owner says, sir, what to say? Sometime everything is fine, sir. We are not getting the raw materials properly. And how can I able to provide the goods to the market? There is no raw material. Okay, then I got the point. Yes, there is deficiency. Now this is a third group of anemia that we have to see, deficiency anemias. Deficiency anemias, we know that for the factory to produce the pen, we need some raw materials. For the RBC to produce, we need some raw material, that is iron, vitamin C, vitamin B12, folic acid, and some copper, and some vitamin E, etc., and thyroxine, etc. These are the raw materials which is actually exactly required for the formation of the RBCs. And owner is telling that, sir, we are not getting these raw materials properly, therefore I am not able to produce the RBCs. So therefore, this is a third group of anemia that is called as deficiency anemias. We will see one by one how to differentiate it. It's quite interesting. Now, owner also says that, sir, sometime we prepare the products, but while I'm carrying to the market, when I'm taking the goods to the market, the road is very, very dangerous and curvy, and it's a hill areas. So accidents are quite common, and that leads to this problem. I am not able to provide the pen to the market. Okay, and he also said sometimes some of the people who are present over here, so they also do some gapla and all, and they stole the pens. So therefore, I am not able to give the pen in a sufficient amount to the market. Now, what does this mean? He says that there is an accident in the road, and therefore they are not able to give the RBCs to the spot or pen to the shop. What is this trauma? This suggests the hemorrhages. Sometimes because of hemorrhages, also there will be anemia. Okay, so this is the third type of anemia, last type of anemia, that is hemorrhagic anemia. He also says that hemorrhages may be occur because of any trauma, or blood loss may also occur. Any condition where there is a blood loss. Blood loss may also occur because of hemorrhoids. Blood loss may also occur because of worm infestation, very common in children. Worms consume the blood, or blood loss may also occur in some of the chronic diseases. So these are basically four types of anemias clinically we have to understand. As far as first, when you see the patient of pallor, first differentiate it is a transient pallor or it is a permanent pallor. If it is a transient pallor, we have got different groups. I told shock, etc. If it is a continuous pallor, a permanent pallor, then you differentiate whether it is a bone marrow pallor, whether it is a hemorrhagic pallor, whether it is a hemolytic pallor, or whether it is a deficiency pallor. This is all what is required. We'll come to the diagnosis within a minute. Now, to show this very shortly, now I can show this in the later part also. I will explain one by one. Now we will see one by one. We will go into discuss. Hope I am audible.
जी सर.
मैडम जब टाइम हो जाता है तो आप बता दीजिए मुझे.
नहीं सर, फुल टाइम है. जितना आप ज्ञान देना चाहे हम लेने के लिए बैठे हैं, बिल्कुल विनीत भाव से. तो ऐसे कोई टाइम का बैरियर नहीं है सर.
Okay, so now we will start with the deficiency anemia. One by one we will go to see. So when I say deficiency, you just remember the example of that factory and all, because it's very helpful. We have the deficiency of iron with B12, thyroxine, vitamin C, vitamin E, etc. Now deficiency may be of two types. Deficiency may be specific deficiency and deficiency may be general deficiency. Okay, so that means the general deficiency means there is also deficiency of iron, there is also deficiency of B12, thyroxine, vitamin C, everything. Now what will be the presentation? What will be the presentation? See, when a factory owner know that raw materials are not available but demand is more, what actually factory owner will do? He will try to convince the population, isn't it? So he don't want to say anything that his factory is not receiving raw material, it will go into shutdown within few months. No, he will try to show that yes, factories, everything is fine in the factory, within few days everything will be fine. Same thing occur in the body also. When there is a pallor, anemia due to deficiency, body will not show any symptoms because it's gradually coming down. So deficiency anemia develops very gradually and child will be active. Although the HB has fallen to 8 or 7, child is still active. Okay, but accidentally if you go for the blood test, you find that yes, there is decreased HB. Otherwise, it is bad. This is a classical nature of deficiency anemia. Deficiency anemia is a chronic anemia, very slowly developing, and child will be active. Now suppose if there is a general deficiency for all the hematomics which is required, then still child will be active. It is never dull. It is active. It is doing all the work, but work efficiency is quite decreased and there will be failure to gain the weight. This is very important. There is a growth failure. Okay, in case of general deficiency anemias. In case of general deficiency anemias. Now suppose if there is specific deficiency anemias, B12 is okay, thyroxine okay, vitamin C okay, folic acid is okay, only iron is not available. Okay, then you don't have any clue at all, because rest of the things are available and only iron is not available. So factory owner try to block it, that nobody comes to know that. So similarly in specific deficiency anemias, what happens? You don't have any clues. Okay, so in specific only one thing is deficient, so baby is growing, there is no growth failure. So in general deficiency anemia you have got growth failure, but in specific deficiency anemia there is no growth failure. Baby is growing well, active, but still there is deficiency of one particular thing. Okay, this is about the deficiency anemia. In the deficiency anemia, again one more thing is that is either it is a chronic or acute. Sometimes deficiencies may starts very acutely. For example, after a surgery it may start, or after celiac disease in children it may start, or after Crohn's disease it may start. Okay, any malabsorption syndrome, the general deficiency may start. So if the deficiency starts very acutely, then what happens? Child will be suddenly sick and child may have the shock. Suppose some disorders suddenly start. Okay, if it's a chronic deficiency, then it gradually comes down. There is no presenting symptoms. Baby is active, as I told, but there will be growth failure. but there will be growth failure, and there will be slowly developing cardiac failure also. Now the thing is, this is a deficiency anemia. Now you have to say, when there is a deficiency anemia, whether there is any role of liver, whether there is any role of spleen. No. So what you get, there is no spleen. Failure is there. There is no splenomegaly. There is no hepatomegaly. Okay. There is no bone marrow problems. Okay. What is happening? Only growth failure is occurring. That is also in general deficiency. Okay. And suppose now, how to identify this condition? If it is exactly there is an iron deficiency, specific iron deficiency, most of the time child will have lack of concentration in the studies. Number one, first noticed by the teacher. Number two, child is having irritability because nerve cells are not getting oxygen because of iron deficiency. So there will be irritability, and exercise intolerance will be there. This will be the first symptoms we will get in case of iron deficiency in children. But if you have got vitamin B as a specific deficiency, if you have vitamin B12 deficiency, then there is nothing is there, because oxygen supply is also good, because vitamin B12 leads to deficiency, leads to macrocytes, and incorporation of the iron inside is okay, and there is no problem. Hemoglobin formation is okay, so these symptoms will not be there. So you cannot get any symptoms. How you have to identify vitamin B12 deficiency? You will have knuckles depigmentation. The digital knuckling in there, that knuckle depigmentation, it will be blackish in color. The knuckles of the digits, okay, black in color. That's the only way out to understand vitamin B12 problem. Sometimes some nerve tingling sensation may be there. So this is all about deficiency anemia. So whenever you see the pallor, first see whether the baby is active. Yes. Whether the baby is splenomegaly is there? No. Any bone marrow problem is there? No. The liver is there? No. Baby is active, but still baby is having some complaint like irritability and all, and on examination there is pallor. Just think that this is deficiency anemia. That's all. Go for the next one. Hemolytic anemia. See, hemolytic anemia, as I told earlier, before the completion of the lifespan of the RBC, it has been destroyed. Okay. So now, premature destruction of the RBC for the various reasons, either HB is faulty or membrane is fault or something like that. Okay. Now, hemolytic anemia, who will work more? The work will be given to, task will be given to spleen, because it has to destroy it and it has to handle it. So first thing is, gradually there will be increase in the spleen. Okay. Gradually there is increase in the spleen size. Splenomegaly will be seen. Then later it will be hepatomegaly. Now in hemolytic anemia, two things can occur. What is that? Some of the hemolytic anemias are congenital and some of the hemolytic anemias are acquired. Okay. Now, congenital hemolytic anemias means problems start from the fetal period itself. Okay. So problems start from the fetal period itself. What exactly happens? For the formation of the RBC, is membrane proteins are very important. Okay, because in the RBC there is no nucleus actually. So membrane itself is its strength. It is able to maintain the biconcave shape and electrons and all on the membranes. Membranes are very, very strong. That membranes are made up of so many proteins. Now suppose one gene is absent which is producing one particular protein, that membrane cannot be formed properly, and that leads to different membrane defects. Okay, if the membrane defect is there, then spleen will going to destroy it, because spleen will only keep only those RBCs which is having normal configuration. If it is abnormal, just remove it. This is a policy of the spleen. Anyway, in congenital what happens, the problem starts from the fetal period itself. And when the baby delivers, baby is already having the problem. Okay, so now gradually this problem develops and reaches the peak. And when it reaches the peak, then there will be the real problem. Now, what are the congenital problems that you will have? Sickle cell anemia, spirocytic anemia, sideroblastic anemia, thalassemia. These are the major problems that we will have in congenital. Here, the RBC which is formed is not in the proper way, proper size, proper shape, and proper membrane. Therefore, spleen will go to remove it. But this removal takes very slowly. It's not at once, because when spleen removes the RBCs, bone marrow goes on producing the RBCs. That is different, that it is producing again deformed RBCs only because of genetic problem. Okay, so this process continues, and when it reaches the peak, see, when the RBCs are destroyed by the spleen, bone marrow has to produce new and new RBCs. So now what happens? Bone marrow increases the work. The workload on the bone marrow increases, and now bone marrow will do the overwork, and because of which the bone marrow undergo hypertrophy or hyperplasia. And as a result, the bone marrow which is present over these skull bones are flat bones will produce the RBC. We know that. The flat bones will go into enlarge. So when flat bones of the skull like frontal bone, parietal bone enlarge, we will have a finding called as a frontal bossing. Okay, this frontal bossing will take place. Just like a bun which is kept over the skull, frontal bossing takes place. So presence of the frontal bossing, then paleness in the face and paleness and anemia, this give a typical facial appearance, and we will call that appearance as hemolytic faces. So in case of congenital hemolytic problems, we will have pallor, we will have splenomegaly gradually developing, or maybe hepatomegaly also, and meantime you will have hemolytic faces. And what about the growth? The growth will be affected because it's a chronic problem. In all the chronic problem, growth will be get affected. Okay, so this is, meantime, if you ask more, you will get a very important clue. What is that? Positive family history, because these are all the genetic problem. Therefore, you will have a positive family history, as in case of sickle cell anemia, spirocytosis, etc. Thalassemia is quite different. We will explain it later. So this is hemolytic anemia with the congenital. Now, hemolytic anemia because of acquired causes. That means there is no problem previously in the fetal stage or after that. Now, something happened suddenly. Suddenly some infection taken place, and afterwards immune system is over exaggerated, and as a result there is production of some antibodies against the RBCs, and RBCs are now destroyed. What you say? This is a sudden problem. So as it is a sudden problem, what happens? There is no growth failure. It is not a chronic problem. It happened just 2 months back. So no growth failure. Child height, weight, etc. will be normal. Okay. But only thing is, now suddenly there is a splenomegaly happening. Suddenly hemolytic faces is coming. Maybe even hemolytic faces will also not come. Face will also not come. You will have sudden development of anemia and pallor. You will have sudden splenic enlargement, and there is no growth affected. So this typically suggests that acquired type of hemolytic anemia. Okay, acquired means later it is attained. Okay, it may be after infection, it may be after some drugs, etc. It is coming. Okay, so this is how we have to differentiate two types of hemolytic anemia. But key factor to identify hemolytic anemia is, if it is a chronic, then it is a chronic presentation and growth failure, splenomegaly. If it is acute, sudden appearance of pallor, splenomegaly, and no growth affected. Not growth affected. No growth is not affected. Okay, so this is how we have to identify. Go to the next one, that is bone marrow anemia. Now this is very important. As I explained in that example of factory, bone marrow is the main factory where the RBCs are produced. Now factory problem is there in the factory itself. Previously in deficiency there is no problem in the factory. Okay, in the hemolytic also there is no problem in the factory. In the hemolytic problem is only in the circulation. Okay, in the deficiency only the problem is there only in the raw material. But here bone marrow factory itself is no problem. Factory itself there is a problem. So what do you mean say? As I told, in the factory few people have poor quality production is there. People are not working well. That is called as bone marrow aplasia. When there is bone marrow aplasia, bone marrow is not able to produce good amount of RBCs, and as a result you will have anemia and pallor. Another is bone marrow insufficiency. That is, or you can call it as bone marrow depression also, bone marrow depression. So now here bone marrow is not able to produce good amount again because they are not paid, workers are not paid properly. Okay, so this may be because of the drugs. Again, the RBCs are not produced. Now bone marrow infiltration, this is very important. This is how we see in case of leukemia. So what happens? Instead of normal working experienced workers, some lobby has introduced some less experienced workers there who don't know anything, but still they are getting salary and they are not producing the good amount of RBCs, and whole factory is now going to shut down, and this is called as bone marrow infiltration. This is what happens in case of uh, bone marrow cancers or malignancies. Okay, so it may be related to red cell or it may be related to white cell, leukemia, etc., myeloid leukemia, lymphoid leukemia, where there is the infiltration of some of the blast cell. Unwanted blast cells are taking the place of normal stem cell, and as a result there is no RBC production, and that leads to the problem. So this is called as bone marrow infiltration. And one more is bone marrow storage disorder. There are so many storage disorders where bone marrow is involved. Some unwanted substances are coming and getting stored, just like in the factory I told, instead of pen, something else has been stored. Okay, so bone marrow storage disorders, these are the four important factors because of which the bone marrow function come down, and that leads to bone marrow anemia. Now you tell me, in case of bone marrow anemia, do you have any spleen working? No, because production itself is not there. Then what to destroy? Spleen को destroy करने के लिए क्या है? Production ही नहीं हो रहा है. Okay, whether there is involvement of a liver? No. Whether there is any problem related to iron and all those things? No. Raw materials is also available. Workers are not working properly. Factory is not conditioned now. That's the problem. So what you will get? You will not have splenomegaly here. You will not have hepatomegaly here. You don't have any deficiency symptoms here. Only symptoms that you get is child is sick looking. This is very, very important. In deficiency anemia, I told child is not sick looking, it is active. In hemolytic anemia, also chronic child may be little sick looking, but not that much. But in acquired, again, child is not sick looking. But in bone marrow anemia, child is always sick looking. Okay, child is always sick looking. And if you go for bone marrow examination, you get pancytopenia, because these intruders like infiltration, etc., that is destroying all the cells. It is also destroying the stem cells of WBC production. It is also destroying the stem cells of RBC production, stem cells of monocyte, lymphocyte. So you get and platelets. So therefore you get a pancytopenia. All the cell count, just go for TC and DC, you find everything. If everything is decreased, yes, it's a bone marrow problem. There is a bone marrow, either aplasia, insufficiency, infiltration, or storage disorders. In the meantime, there is no splenomegaly, still there is a pallor. There is no hepatomegaly, still there is a pallor. Child is looking sick. On examination, you find pancytopenia. Yes, diagnosis is done. This is one or the other cause of bone marrow anemia. That's all. We'll go for the last one, hemorrhagic anemia. So what is the problem here? Everything is fine, isn't it? In hemorrhagic anemia, everything is fine, but when you are taking the goose to the market, in between there will be accident, or a few people will take away the mal, etc. There is no problem in the production. There is no problem in the raw material. Nobody is coming and destroying. Okay, there is no rowdies coming and destroying, just like in case of hemolytic anemia. What is the problem? The problem is the road and driver. Okay, there will be some accidents going on. This is a typical of a traumatic, okay, or hemorrhagic anemia. Because of hemorrhagia, because of hemorrhage, there will be blood loss, and that blood loss leads to pallor and anemia. So this blood loss may be occult, as it is not seen. Occult means which is not seen, as it is happening in case of GIT or urinary tract. Hematuria is going on. Okay, melena is going on, unnoticed. Okay, occult. So that may lead to anemia. So here it is not bone marrow anemia, it is not hemolytic anemia, it is not deficiency anemia, it is just because of loss of blood. Similarly, it may be because of some traumas. Okay, it may be IVH, intraventricular hemorrhage going on, subdural hemorrhage going on. Okay, hemorrhoids taking piles, blood loss is there. Okay. Suppose adolescent girl and all, menorrhagia, etc., excessive blood loss in the menstrual period. So these are the causes of anemia. So how to identify that? You don't have any liver here, you don't have any spleen here. Child is not sick looking because it's not bone marrow problem. Okay, there is no specific deficiency problem will be seen. Child will be active, or patient will be active. But thing is, okay. So how to differentiate it here? In such, it's because of occult. You just go for. It is very difficult to assess the iron contents. Therefore, you have to go for trial and error method. That I will discuss. So this is the fourth type, that is hemorrhagic anemia. Okay, I hope this much is very clear. I just want to ask whether the audience are following me or not.
जी सर, बिल्कुल सारे सुन रहे हैं सर. जी सर.
Okay, now how to go ahead. Now after these slides, we'll go for some of the cases. Then the things will be very, very clear. How to go ahead. So when I go to the market, I didn't find the pen. That means there is paler. Okay, now I have to see where is the problem, isn't it? So I can't simply shout at shopkeeper. Pen is not available. Paler in the body is there, or anemia is there. I cannot shout at simply shopkeeper why there is no pen. I have to see the cause. I have to see whether it is a bone marrow problem, deficiency problem, hemorrhagic problem, or it is a hemolytic problem. Now, where should I go? And we have to investigate. I cannot go to the factory every time, isn't it? If the problem is there in the hemorrhage, that means problem in the road, I cannot go and inquire in the factory. If the problem is there with the looters, rowdies, etc., hemolytic, I cannot go and blame the bone marrow. I cannot go and blame the liver or spleen. Okay, so now this is what I have to investigate. Okay, so investigate the transport, raw materials, factory, driver, truck, as far as the needs is required. Okay, so with this we have come to the completion of one part. Now we will see some of the cases one by one, by which the things will be very, very clear. I hope so. Now this is the first case. A very much worried mother brings her 1-year-old child to the OPD, and complaint of the mother is, my child is very pale, and this child is, when you examine, it is exclusively breastfeeding. This child is exclusively breastfeeding up to 9 months, and now also she is taking the breastfeed, and she is also taking some half diluted fresh milk like cow's milk, and occasionally mother is giving cereals. Okay, child is already 1 year old, mother is occasionally giving cereals, and still almost all predominantly in the milk diet is breast milk and as well as cow's milk. Now baby is quite active and baby is happy looking. Mother is worried. Mother is worried because somebody told her that your child is looking so much of pale. Child is looking very pale. So she brought the child. And when I do the physical examination, weight of the child is 8.5 kg. I think for a 1 year, 8.5 kg is okay. Length is 74 centimeter. For 1 year, I should have 75 centimeter. It's 74. That is also okay. Heart rate 120. That's also okay. Respiratory rate 28. That's also okay. But on examination, paler is plus. Paler is plus. And liver span is 8 centimeter. Liver span is 8 centimeter. Spleen is not palpable, and there are few signs of vitamin D deficiency. They're like bow legs, like that. Some bone problems are there. I think so. On external appearance, it looks like some bones are bowed like that. Of course, that is quite normal in 1 year age. So this is the presentation. Now we have to decide only 4 things. Child is coming with a paler, whether this child is having deficiency anemia, bone marrow anemia, hemolytic anemia, or hemorrhagic anemia. That's all. Now we will go one by one. Can I ask anybody have any idea?
Nutritional deficiency, sir, because of iron deficiency in the milk.
Maybe we will discuss the case. Okay. Case 1, we'll have the discussion. Okay. See, this mother complains that my child is pale, isn't it? It is not identified by the doctor or investigation. Mother herself telling that my child is pale. What it suggests? It is not a mild paler. It is not mild anemia. When mother is able to notice the paleness, that means this is not mild. Rather, this is either moderate or severe paleness. Okay. So if a doctor on examination telling that your child is pale, okay, it may be a mild pale. But an uneducated mother is also able to identify the paleness. That means it is very striking. So either it is a moderate or severely pale child. But there is no associated vomiting, diarrhea, and infection, etc. If there is vomiting, diarrhea, infection, etc., is there, then we can assume that there will be some loss of nutrients, isn't it? But through the diarrheal, stool and vomiting and all infection, the loss of nutrients will be there. No such symptoms are there. Now feeding is there up to 9 months. Mother is telling that up to 9 months I was giving breast milk. Actually, we say that up to 6 months we have to go for exclusive breastfeeding. After 6 months, there is a need of extra calories. Therefore, we have to go for supplementary or complementary feeding. Complementary feeding. Okay, but in this case, mother is feeded the child only with the breast milk up to 9 months. And meantime, she is also giving. Now also she is giving breastfeeding, and she is also giving the cow's milk. She is also giving the cow's milk, and cereals are not yet properly started. Now, this is not a hemolytic anemia because on examination there is no splenomegaly. Okay, do you think it is a bone marrow anemia? No, it is not bone marrow anemia because child is not looking sick. Is it hemorrhagic anemia? No, it is not hemorrhagic anemia because there is no history of an injury, chronic blood loss, etc. What is left with us is, yes, this is a deficiency anemia. This is deficiency anemia. Now, once you know that this is deficiency anemia, now you have to see whether it is a chronic deficiency anemia or acute deficiency anemia, and whether it is general deficiency anemia or whether it is specific deficiency anemia. Okay, so chronic or acute, we know that in this particular case there is no any acute presentation, suddenly child falling ill and suddenly child becoming fail. No, there is no such acute presentation. So definitely this is a chronic deficiency anemia. Now see whether it is a general or specific. Now if it is a general, I told you that in case of general deficiency anemia you will have growth failure, but in this case there is no growth failure. Height and weight is almost all okay. Okay, so this is not general growth deficiency anemia. This is specific growth specific deficiency anemia because height and weight is normal. So this is a deficiency anemia, chronic type and specific type. Now what is the specific in this particular case? Milk diet is given, isn't it, up to 9 months, and now also milk diet is given. We know that milk diet is cow's milk is given, and cow's milk is very poor source of iron, so and also vitamin D. So probably this is a case of anemia which is predominantly specific deficiency due to predominant milk diet and less cereals at this particular age, and this shows the symptoms of iron deficiency anemia. This particular anemia is because of iron deficiency, and on inquiry I asked the mother any other symptoms. Then mother told child is very much irritable, she is not sleeping properly at night and chid karta hai, bachcha bahut chid hai. So again the things are clear, it's because of iron deficiency. And I also find some finding in the examination, there is some Bolex etc is there, maybe because of vitamin D deficiency because of this milk diet. So now things are very clear, this is a deficiency anemia, specific type, iron deficiency anemia. I hope you understand. Now we go to the second case. Now this is quite interesting. Mother brings a 2-year-old active child. Okay, child is very active. Mother brings a 2-year-old active child presented with a very severe pallor. Severe pallor. Just by distance itself you can identify. And when you ask the history, there is a history of exclusive breastfeeding up to 5 months, and then the complementary feeds were started. That suggests that yes, feeding pattern is good. Up to 5 months or 6 months we'll go for exclusive breastfeeding. Then there is a need of starting complementary feeds. That has been done here. Now at present, child is on family diet. So what we expect is after 1 year, child has able to take the family members' diet. What adults will eat, same has to be taken by the child also to some extent. This is our minimum expectation. So here in this case, child is taking the family diet, and also child is taking some small amount of cow's milk. That's okay. Small amount of cow's milk. Now here in this case, there is a past history of similar illness. What is that similar illness? Severe pallor. About 6 months ago, now it's a 2-year-old child. 6 months ago, there is a past history of similar illness of severe pallor. The cause is exactly not known, but one blood transfusion has been done. For severe pallor, they have gone for blood transfusion. Now 2-year-old child, now look at the height and weight. Child is 11 kg and length is 86 centimeter. Length is 86 centimeter for 2 years. And the child is 11 kg for 2 years. It's quite we have to see some of the things here. Pallor is plus. There is mild icterus. there is mild icterus. Very important point. Pallor and icterus. Now you have to imagine pallor and icterus coming together. Pallor and jaundice coming together. Now there is no abnormal phases. Okay. There is no hepatosplenomegaly and other systems are normal. Now this is quite interesting, isn't it? See, in this child, if you discuss the case, feeding is reasonably good, isn't it? They have started complementary feeds in the 6 month itself. Everything is fine. So when the feeding is good, everything is good, I will decide that yes, there is no deficiency anymore. Yes. Now also, I will see whether child is sick. No, child is not sick. They have told that there is a history of blood transfusion, child is having pallor, but child is not sick. Again, one thing is clear, this is not related to bone marrow. If by bone marrow, child by this time would have been definitely sick. Okay. Now, there is no history of bleeding, trauma, etc. Yes. Now again, it is very clear, it is not hemorrhagic anemia. So now all the three are excluded. What is left is it is a hemolytic anemia, isn't it? It is a hemolytic anemia. But what I told earlier, if you want to have hemolytic anemia to diagnose, either liver or spleen has to enlarge, isn't it? See, this is a case where spleen is also not enlarged, but we have already excluded all the three types of anemias. Left is only hemolytic anemia, but spleen is not enlarged, liver is not enlarged. Jaundice is also very mild. Jaundice is also very mild, but there is a history of blood transfusion. History of blood transfusion. Now, if it is hemolytic, as we assume, now we have to see whether it is a congenital or acquired. Among the hemolytic, congenital or acquired. If a congenital, it will be starting from the birth itself, and growth will be affected, as I explained earlier. But there will be hemolytic phase also by this time. 2 साल का बच्चा है, by this time definitely the hemolytic phase also develops. But in this case there is no hemolytic phase. Okay. And growth is also almost all normal. ठीक है. Of course weight is little less, height is normal. जब height normal है हम बोलते हैं कि कोई chronic problem नहीं है. ठीक है. जब weight normal नहीं है तो हम बोलते हैं कुछ acute problem हो सकता है. चलो. No. So now I think that is a congenital, but in congenital it will be from the birth itself and growth will be affected, but growth is not much affected. Weight थोड़ा कम है, फिर भी growth is not affected because the height is okay. If it is an acquired case like sickle or spherocytosis, there will be jaundice and splenomegaly. आपको पता है कि sickle cell and spherocytosis abnormal RBCs are formed and it will be destroyed by the spleen. Once spleen destroyed, the spleen will undergo enlargement, and in the meantime heme metabolism takes place and there will be jaundice. And in case of spherocytosis and sickle cell, we will have some other symptoms like sickle crisis, hand, foot pain, etc. ऐसा कुछ भी नहीं है यहाँ पे. Everything is fine. Okay. So now we have to see. One thing is very clear. One thing is clear. It's a congenital. Okay. क्योंकि थोड़ा बहुत growth affected है. It is congenital. But there is no spleen, there is no liver, and nothing is there. Hemolytic phase is also there, not there. Now we have to see which is that congenital condition, which is slowly progressive, without liver and spleen enlargement, and without jaundice or mild jaundice, and without much growth failure. Now we have to see that. Answer is basically is thalassemia, because thalassemia is a problem where the globin chains of the hemoglobin are not properly formed. It is a structural problem, genetic problem. And hemoglobins will be, that means RBC will be not properly formed, it will be destroyed. But in thalassemia, we will have 3 types. Minor, major and intermediate. Okay. If it is a major or intermediate thalassemia, where the destruction is very, very massive, by this time child would have been developed either splenomegaly or liver hepatomegaly and hemolytic phases. But is that hemolytic? Now this condition is that hemolytic condition where the problem is not much severe. Therefore, the spleen is not enlarged, liver is not enlarged, and in between they have given one blood transfusion to correct the situation. So actually this is a hemolytic anemia only. Okay. Therefore, jaundice is also very less. Jaundice is also not mild. But this is a thalassemia minor condition. This is a thalassemia minor. This is not thalassemia major. It may be thalassemia minor or it may be thalassemia intermediate. Now, one important question is why jaundice is not developed? अगर thalassemia minor है तो भी इतना दिनों से जब डिस्ट्रक्शन चल रहा है jaundice आना चाहिए था, but jaundice बहुत कम आया. See, here lies a very important clue. In congenital condition like spirocytosis or you say about the sickle cell anemia, after hemolysis the jaundice develops very early because सिकल सेल में क्या होता है कि वहां पे हीमोग्लोबिन का जो अंदर कंटेंट है वो नॉर्मल है. स्पिरोसाइटोसिस में हीमोग्लोबिन का जो कंटेंट है वो नॉर्मल है. जब वो डिस्ट्रॉय होता है तो ज्यादा हीमोग्लोबिन रिलीज होता है और हीमोग्लोबिन को रिलीज करते करते हीम मेटाबॉलिज्म होते होते बिलिरुबिन बन गया, जॉन्डिस बढ़ गया. बट इन केस ऑफ थैलेसीमिया व्हाट हैपेंस? थैलेसीमिया इज अ स्ट्रक्चरल प्रॉब्लम. हीम और ग्लोबिन, वो ग्लोबिन का फॉर्मेशन में ही प्रॉब्लम है. अगर ग्लोबिन में दो चेन है, एक अल्फा चेन है और बीटा चेन है. अल्फा चेन में अगर प्रॉब्लम है इट लीड्स टू अल्फा थैलेसीमिया. अगर बीटा चेन में अगर प्रॉब्लम है तो इट लीड्स टू बीटा थैलेसीमिया. बट ये हीमोग्लोबिन अंदर आने से पहले ही ग्लोबिन का चेन वहां पे बनता है. ओके, सो दैट मीन्स द डिस्ट्रक्शन स्टार्ट्स मच अर्लियर इन थैलेसीमिया. हीमोग्लोबिन अंदर आके वहां पे इनकॉर्पोरेट होने से पहले ही जो है वो आरबीसी का डिस्ट्रक्शन होता है बिकॉज ग्लोबिन चेन ठीक नहीं है. तो जब हीमोग्लोबिन ही नहीं है तो हीमोग्लोबिन का मेटाबॉलिज्म का बात भी नहीं है, बिलिरुबिन का बात भी नहीं है, जॉन्डिस का बात नहीं. इसलिए इन केस ऑफ थैलेसीमिया यू विल हैव मार्क्ड पेलर तो बहुत ज्यादा रहेगा बिकॉज प्रोड्यूस नहीं हो रहा है आरबीसी. बट आपको जॉन्डिस बहुत लेट में मिलेगा. If it is only a case of severe thalassemia, then only you will get the jaundice. Otherwise, you will not get the jaundice. You can get the mild icterus or jaundice. So this is very important part. So this is a case of basically hemolytic anemia. उसमें भी एक twist है. A hemolytic anemia which is not looking like a hemolytic anemia may be thalassemia minor. I hope you understand this. Okay. Audience, are you enjoying or not?
जी सर, बिल्कुल.
Now you go to the next case number 3. Here, a 2-month-old infant is presented with a pallor and noticed since last month. ये notice कब किया है कि last month से, last 1 महीने से. बच्चे का एज है just 2-month-old infant. अभी पैदा होके 2 महीना ही हुआ है. And since last month mother noticed some pallor and last few hours back child had seizures. बच्चे को convulsion आया and mother feel कर रही है कि mother assumes that the lower limb is little weak. थोड़ा बहुत लो उसका जो है sorry upper limb is little weak. थोड़ा बहुत इसमें hemiparesis है and there is also a convulsion. Okay, ये just अभी 1-2 घंटा पहले हुआ. बच्चे का एज है 2 महीना. 1 महीने से मदर नोटिस कर रही थी पेलर. उसने सोचा कि कोई बात नहीं है. बट अभी कुछ घंटा पहले बच्चे को जो है एक कन्वल्शन आया और उसको लग रहा है कि इसका अपर लिम्ब थोड़ा राइट अपर लिम्ब है वो थोड़ा वीक है. दिस इज द प्रेजेंटेशन. यस, व्हेन यू कम ओवर हियर आई आस्क्ड द हिस्ट्री. जब मैंने हिस्ट्री पूछा so then they give the history that child is born after a forceps delivery. Instrumentation हुआ है. Child is cried immediately after birth. There is exclusive breastfeeding. 2 महीने से exclusive breastfeeding में चल. They go for the physical examination. Weight of the child is normal 3.6 kg. 2 महीने के लिए 3.6 kg. ओके, एक दिन में जो है 30 ग्राम्स बढ़ना चाहिए. तो इस हिसाब से in 1 month we have expect 900 grams. It's okay, almost all okay. Birth weight is 2.5. The length is 55 centimeter. That is also quite okay, not problem because at birth we'll have 50 centimeter. For just 2 months is 55 centimeter. Head circumference is 40 centimeter. थोड़ा ज़्यादा है इस age के लिए. It's quite higher for this particular age. At birth, the child will have head circumference of 35 centimeter, 36 centimeter. Now it is quite higher, 40 centimeter. Okay. Pallor is plus and there is no icterus. And liver is 2 finger. That is quite normal. थोड़ा बहुत बच्चों में liver जो है नीचे मिलता है. And spleen is very soft and not palpable. Spleen is not palpable. Now on examination, as the mother says, there is a convulsion, there is a mild weakness in the right upper limb, and when I see the anterior frontal is bulged, mildly boggy, thoda bulged. This is the presentation of the patient. So have you got any idea what may be the problem? Anybody?
Intracranial hemorrhage.
There is no such things. Anyway, we will see. Any other ideas? Any other?
Maybe hemorrhage there, intracranial.
No. You mean to say it is hemorrhagic anemia? Is it a hemorrhagic anemia? We are focusing on pallor because main complaint of the mother is pallor and that convulsion. So pallor may be, according to you, the pallor may be hemorrhagic. I hope so. We will see the case. See, child presented with the symptoms so early, isn't it? 2 months of age. It is too early. And a child would have been born with anemia. When I say child is having anemia at 2 months, usually what I suspect is this child would have been born with anemia, because till last 2 months you are taking only breast milk, and breast milk contains almost all the things, and iron stores are also good from the maternal side, baby receives. So there is no much problem, but still there is anemia, pallor in 2-month-old baby. Now I think it may be a congenital anemia or it may be acquired anemia, isn't it? So this child is born with the anemia, or child developed anemia after birth. I have got only 2 years of span in between. Now if it is a congenital anemia, suppose child is born with, because child is presented at 2 months of age with the pallor, then I will have to see whether it is a congenital or acquired. So if it is a congenital anemia, my most common suspicion is either ABO incompatibility or RH incompatibility. If it is ABO incompatibility or RH incompatibility, child would have anemia which is there, but it should also have jaundice, because ABO and RH incompatibility is a destruction of the RBCs. But there is no jaundice in this case. So most common causes of congenital anemia is excluded now. Now I'll go for some acquired. It may be because of some of the bleeding problems. Child may be having some hemorrhagic problems. If child is having really bleeding problems, bleeding disorders, at 2 months of age, child should have a bleeding spot in the body. There may be some bleeding coming from the nose, bleeding coming from the gums or elsewhere in the body, or in the stool, etc. That history is also not there. So this is not a bleeding disorder also. Okay. Now, there is one more anemia which is called as physiological anemia. You may be knowing cord blood contains about 18 grams of hemoglobin, but as the day passes, the hemoglobin count gradually falls down, and by the end of 8th week, the hemoglobin of the child comes to 10, and after 8th week, again gradually the hemoglobin level going to rise, and this particular hemoglobin downfall which occurred around 8th week, this is called as physiological anemia. This is called as physiological anemia. Now I hope that there may be physiological anemia, isn't it? The question comes why there is a convulsion, that we will see. But if it is a physiological anemia, why the anterior frontal is bulged and why there is a convulsion, isn't it? So this is not physiological anemia. This is not a hemorrhage leading to anemia because of bleeding disorders. Okay, this is also not a congenital problem. Okay, it may be an acquired problem, but there is no history. Now, where this case will going to fit? See, do you think it is a deficiency anemia? No. At 2 months of age, deficiency is less likely. Okay, because child is taking breastfeeding, deficiency is less likely. Do you think it is a bone marrow anemia? No. Why? Because in bone marrow anemia, spleen, etc. Child will be sick, but it is not like that. Do you think it's a hemolytic anemia? No. If it is hemolytic anemia, spleen will be enlarged, liver will be enlarged, and hemolytic phases will be there. So now the only option left is hemorrhagic anemia. Yes, hemorrhagic anemia. Yes, it may be, but how to understand this case? See, in this case, anterior frontal eye has been bulged and mildly boggy. Okay. So when anterior frontal eye is bulged more than the normal, it is definitely because of increased intracranial pressure. It is definitely because of increased intracranial pressure or some other space occupying lesions. Space occupying lesions are less likely in 2-month-old baby. Boggy without intracranial lesion. So now there is some cranial bleeding is taking place, which is leading to increased intracranial pressure, because intracranial pressure increase can occur in different cases. Okay. Now, if AF is bulged, there are two things are there. One is AF is bulged. When the AF anterior frontal is bulged, the anterior frontal is bulged with pulsation, and anterior frontal is bulged without pulsation. If you keep the hand over the anterior frontal, then you feel the pulsations. Okay. So boggy without any intracranial tension means it may be because of simply frontal bossing. But AF without any pulsation, definitely it is intracranial tension. Anyway, ठीक है, AF बल्ज हुआ है, AF अगर बल्ज हो गया तो कभी कभी फ्रंटल बॉसिंग जब होता है ना, तब भी AF बल्ज होता है. अगर फ्रंटल बॉसिंग की वजह से AF का बल्जिंग हुआ है तो वहां पे आपको पल्सेशन तो मिलेगा. अगर कोई इंट्राक्रेनियल प्रेशर बढ़ा है, इसकी वजह से बल्जिंग हुआ है, तो वो पल्सेशन नहीं मिलेगा. सो इस केस में क्या है कि AF तो बल्ज है बट पल्सेशन नहीं है. इसका मतलब है दिस इज डेफिनेटली ए केस ऑफ इंट्राक्रेनियल प्रेशर इंक्रीज्ड. Increased intracranial pressure is there. Now we have to think what is the cause of increased intracranial pressure. Now if you go to the history, there is a history of forceps delivery. Instrumentation ka history. So now there is a history of a forceps delivery. So probably because of forceps delivery, there is some hematoma is formed. Cephalohematoma is formed. Hematoma is formed. And this hematoma is going on increasing. That is the difference between cephalohematoma and caput succedaneum. कैपुट सक्सीडेनम, कैपुट एक बार बन गया तो पैदा होने के बाद जो है वो बढ़ेगा नहीं, वो कमी होगा. बट हेमाटोमा क्या है कि वो बढ़ सकता है ऑन गोइंग ब्लीडिंग की वजह से. ठीक है. सो इन दिस केस द सेम थिंग आई थिंक हैपेंड. द हेमाटोमा, द इंजरी हैपेंड एट द टाइम ऑफ द इंजरी, देन हेमाटोमा फॉर्म्ड एंड लेटर ऑनवर्ड्स हेमाटोमा गोइंग ऑन इंक्रीजिंग. ओके, सो दैट मे बी द कॉज. नाउ सी, नाउ वी हैव टू फाइंड आउट द साइट, इजंट इट, वेयर एग्जैक्टली द ट्रॉमा हैपेंड. अगर फॉरसेप्स डिलीवरी में ट्रॉमा हुआ है तो हो सकता है कि वो क्रेनियल बोन्स में हुआ है, हो सकता है कि पैरेंकाइमा में हुआ है, ब्रेन पैरेंकाइमा में हुआ है. ठीक है. हाउ टू आइडेंटिफाई दैट? इफ इट इज बिकॉज ऑफ ब्रेन पैरेंकाइमा लाइक इंट्रावेंट्रुलर हेमरेज, इंट्राक्रेनियल हेमरेज, देयर विल बी पेलर व्हिच इज वेरी सडनली आएगा, एंड एक्यूट ब्लड लॉस विल बी देयर, एंड सीजर appears, convulsion appears within 1 or 2 days, yeah, immediately. Okay, but up to 2 months there is no seizure in this case. So definitely it is not IVH, intraventricular hemorrhage तो नहीं है. Now this is meningeal layers में hemorrhage हुआ है, that is scalp layers में. So what are the most common cause of scalp layer hemorrhage is subdural hematoma. Because of forceps delivery, there is subdural hematoma formed, and this hematoma is becoming ongoing. A large hematoma is formed, and as a result, the pressure increases in that subdural place. Subdural pressure now transmitted to the brain. Then baby start convulsion. Meantime, because of intracranial tension increases, there is bulging of the anterior frontal layer. So this is a hemorrhagic anemia. Basically, this is a hemorrhagic anemia. ठीक है, वो तो क्लियर था मैं. बट हेमोरेजिक एनीमिया में क्या हो सकता है? बिकॉज ऑफ सबड्यूरल टाइप ऑफ हेमोरेज. Okay, I hope this is clear. So this is an example for a hemorrhagic type of anemia. Now you go for case number 4. A 2-month-old infant with a pallor. Now this is really a challenge. Okay, 2-month-old infant with a pallor noticed few days ago, and there is no other symptoms. इतना ही हमारा history. Only this much of history. Child is having 2-month-old. There is a pallor noticed by mother few days back, and there is no other symptoms. Okay. Now I will go for examination. Child is on exclusive breastfeeding since last 2 months. Okay. Physical examination. Weight is 4.3 kg. 2 साल 2 महीने के लिए 4.3 is well and good. बहुत अच्छा है. Length is 53 centimeter. Okay, length I'm little worried. 1-2 सेंटीमीटर ज्यादा होना चाहिए था, but okay. Head circumference is 38 centimeter. It's also normal for this age. At the birth it will have 35. Now it is 38. Okay, but pallor is plus plus plus. Pallor is plus plus. Okay. Now when I see liver is soft and spleen is also soft. Spleen is very just palpable. बहुत कम है. Only mildly palpable. Very just palpable. Sometimes spleen and liver palpation is quite normal in the unit. Baby is looking sick. This is a complaint of the mother. Baby is looking sick. बेबी एक्टिव नहीं है, ठीक से सोता नहीं है, चिड़चिड़ा भी है. Baby is looking sick. It's not active. It's not playful. Okay. And there is also a malformation of the forearm and thumb. मैंने examination किया. Some thumb and as well as forearm में थोड़ा malformation है, ठीक से नहीं बना है bones. Okay. That means thumb is also short and right-sided forearm is also little short. This is the only presentation. Very mild. Now we have to see. In the history, if you see, the striking feature that we'll get is babies not looking sick, and also there is some malformation in the limbs. These are the two important things. Apart from that, in the history, you are not getting anything, isn't it? Now we'll go further. Yes, it is 2 month old, weight is okay, but length gain is less. वो मैं बात कर रहा था. So length gain is not up to the mark, but okay. So one thing is very clear, it is not deficiency, isn't it? In the deficiency, child will be always active, it is not sick. And such an early age deficiency is uncommon. And do you think it is a hemorrhagic? No, there is no history. There is no history of hemorrhagic. Do you think it is a hemolytic? Hemolytic spleen is quite enlarged, but I cannot say that whether it's really spleen or normal variant. But one thing is there is no jaundice. Icterus तो अभी तक नहीं है. So I also doubtful about hemolytic. Now, is it bone marrow? There is no jaundice. Liver spleen doubtful. Baby is looking sick. Yes, this favors towards bone marrow anemia. This favors towards bone area. Everything is normal looking, but baby is sick looking. That's bone marrow anemia. Now, if you want to see bone marrow problem in 2 months of age, at the age of 2 months, I told already, factory, just remember the factory. 4, bone marrow aplasia may be there, bone marrow insufficiency may be there, bone marrow infiltration may be there, and bone marrow storage disorders may be there. Isn't it? If it is a bone marrow storage disorders, at the age of the 2 month, it is again less likely. Store होने के लिए बहुत time लगता है. ठीक है? Bone marrow infiltration, again at the age of 2 month, less likely. Bone marrow insufficiency, ऐसा कुछ drug का history नहीं है. There is no particular drug का history है. And nothing is there. So this may be a case of bone marrow aplasia. Bone marrow itself is not properly formed. At the age of the 2 month, do you have any condition? Yes, there is one condition. That condition is called as Diamond-Blackman's anemia. Okay, Diamond-Blackman anemia. So this is a bone marrow anemia. In the bone marrow also it is bone marrow aplasia anemia. Okay, so this is possible. And what favors is limb deformity. This particular Diamond-Blackman anemia is associated with the limb deformities. Yes, limb deformity is there. Thumb is not properly formed and forearm is short. Yes, so this is a case of bone marrow anemia, primarily bone marrow anemia. The bone marrow anemia, it is bone marrow aplasia anemia. And if you want to name the disease, it is Diamond-Blackman's anemia with the limb defects. Okay, so this is case number 4, and this is the example of bone marrow anemia and how the patient of bone marrow anemia looks like. Now go for the next day. 6-year-old child presented with a lump. This is also quite interesting, really. 6-year-old child presented with a lump in the left hypochondria, as noticed by the mother few months back. उसका जो है left hypochondric area में जो है, so there will be some. So a 6-year-old child presented with a lump. Mother noticed. Okay, just few months back. On direct questioning, मैंने direct question किया कि 6 साल का बच्चा है. It's not an infant है ना, 6 साल का बच्चा है. So I questioned the child, mother. He says that I feel fatigue. बहुत fatigue होता है उसको. And there is no history of any consanguinity. फैमिली के अंदर जो शादी है सब कुछ, क्योंकि आई वांट टू क्लियर दी व्हाट यू से जेनेटिक प्रॉब्लम्स. सो देयर इज नो हिस्ट्री ऑफ कंसैंग्यूनिटी, बट देयर इज ए पास्ट हिस्ट्री ऑफ जॉन्डिस एट 4 years of age. जब वो 4 years का था, he has got the jaundice. Okay, 6-year-old child at the age of 4 years he has a jaundice. Then I ask immediate next question, whether it is having nausea and vomiting. Mother told no nausea and vomiting. Then I excluded hepatitis. There should be fever, there should be nausea and vomiting. So this is not that case of jaundice with the hepatitis. Okay. Now he says that there is a high colored urine. थोड़ा बहुत यूरिन का कलर हाई कलर था, और after 1 week it is resolved. Now I have gone to the physical examination. On physical examination, weight of the child is 19 kg. Okay. And height is 103. See, 19 kg for 6 year is not good. Then the height is 103. Oh, no, again, because by end of 4 years, you have to achieve 100 centimeter. Okay, now 6 years, only 103. Again, it is downfall. Okay, there is moderate pallor is there. And no icterus nahi hai. Okay, jaundice is not there. Pallor is there. Liver examined, liver is almost a normal span, 7 centimeter. But in the history also she says that left hypochondria there is a lump. So I am doubting about spleen, and when I palpated, yes, spleen is palpable, 5 fingers. Spleen is palpable. Now almost all you are clear. There is a history of consanguinity है इस केस में, फैटिक भी है, एक बार जॉन्डिस हो चुका है, एंड वेट हाइट दोनों ठीक नहीं है, ग्रोथ फेलियर है, एंड स्प्लीन इज आल्सो एनलार्ज्ड बाय 5 fingers. Point towards, yes, anybody? What is this?
Sir, I think it is splenomegaly with bone marrow depression.
Splenomegaly with bone marrow depression.
Hemolytic anemia, sir.
Yes, it is hemolytic anemia. Okay, but there is no jaundice. If you say it is hemolytic anemia, it's a 6-year-old child. There is a history of jaundice. एक बार previously history of jaundice है. Presently there is no history of jaundice. Presently there is no jaundice. पहले एक बार हुआ था उसको jaundice, but अभी तो नहीं है. Yes, anyway, we'll go to the case. So there is a lump in the left hypochondria. No doubt, it is a spleen, isn't it? And it is also seen by the mother. Mother ने भी बोला है कि there is a lump. So it must be a massive. If the mother is noticing that lump, it's quite sure that obvious that it is definitely a massive swelling. Okay, and there is also fatigue. So जब fatigue है तो there is massive destruction of RBCs, and also iron is also not properly managed. Okay, so there will be anemia with leading to fatigue. Now what happens? According to some, as you told, it may be a bone marrow anemia like leukemia. But if it is a bone marrow anemia, child should look sick. Okay, child should be sick. But spleen will be bone marrow anemia. There is no question for spleen. If it is a bone marrow anemia, that's in the later part you may have the spleen. Otherwise, in the bone marrow anemia, there is no splenic enlargement. But one thing is very clear: splenic enlargement is there in this case. Okay. And therefore bone marrow infiltration like leukemia etc., that is also excluded. So spleen is there. One thing is very clear, it is hemolytic problem. Bone marrow is not there because the child is not sick. Now although no jaundice at present, abhi usko jaundice nahi hai, but he had a history of jaundice. Now growth velocity is very, very low, isn't it? Growth velocity is very low. Stunting is there. If you see the height is very less, stunting is there. So what it suggests, when growth velocity is there, low, and stunting is there, it's a chronic problem. It's a chronic. Now think, which is that hemolytic problem, which is chronic with the spleen? Yes, this is a case of, and this will be supported by one more finding. What is the history of consanguinity? So you have to suspect about a chronic problem, chronic hemolytic problem with the spleen, which is of genetic onset. Yes, we have got history of consanguinity. Therefore, this is a case of sickle cell anemia. This is a case of sickle cell anemia. This is not thalassemia. This is a case of sickle cell anemia because in thalassemia we didn't find the jaundice so early. This is not bone marrow, there is no jaundice. But here there is a history of jaundice previously. At present he is not having, but he had a history of jaundice. So again, this point towards this particular case. This is a case of a sickle cell anemia. I think this is the last case I will go. Last case, yes. Child with 4 year. Child is 4-year old and presented with a fever for a week. Very interesting case. Child is having 4-year-old child. There is a fever for 1 week, and he is also having generalized weakness for the last 4 days. No other complication. और कुछ नहीं है उसको. 4-year-old child presented with the fever for 1 week. Now he is having generalized weakness, and child noticed pallor. Sorry, mother noticed pallor. This particular fever responds to the paracetamol, and after few hours, but child is irritable. Most of the time, fever persists in the same way. Fever is persisting on the same way. Okay. On physical examination, child is sick looking. Child is irritable. Pallor is plus. No icterus. Jaundice nahi hai. Abdominal distension is there to some extent. Hepatomegaly is there. There is no splenomegaly. Thoda bahut hepatomegaly hai. Okay. And some of the lymph nodes are also enlarged. There is no any skin rash. And this is the investigation report. What is that? HB is 6. HB come hai. WBC is 2000. That is also low. Polymorphous 12. That is also low. Lymphocyte 84. ये थोड़ा बड़ा है. थोड़ा नहीं, ज़्यादा बड़ा है. Monocyte only 2. Eosinophil 2. Platelet is only 60,000. So what it suggests? This suggests pancytopenia. A child with a pallor. There is a history of mild fever. Okay? And weakness is there. Child is sick looking. Child sick looking बोलते ही हमें समझ में आ गया this is bone marrow problem. Now उसमें fever भी है. ठीक है? And physical examination आपने किया कि jaundice नहीं है, but pallor है. तो hemolytic नहीं है. ठीक है? Sick looking है, irritable है. But when you go for the simple HBTCDC, you find pancytopenia. सब कुछ नीचे गिर गया. So this is definitely factory. फैक्ट्री में क्या हुआ है? कुछ अनवांटेड लोग आके वहां पे इन्फिल्ट्रेट हुए हैं, वो काम नहीं कर रहे, इसलिए सब कुछ फैक्ट्री का इंप्रेशन इंडेक्स जो है नीचे आ गया. दिस इज द केस ऑफ इन्फिल्ट्रेशन, बोन मैरो इन्फिल्ट्रेशन. वन वी हैव सीन बोन मैरो एप्लेसिया. नाउ दिस इज द केस ऑफ बोन मैरो इन्फिल्ट्रेशन बिकॉज सिक लुकिंग चाइल्ड विद द पेलर pancytopenia. Okay, now we'll see what exactly. Yes. Is it deficiency? No, because there is no fever, icterus, and hepatosplenic, etc. Hemorrhagic? No history. Bone marrow? Yes. Child is irritable, sick looking, pallor, and lymph nodes are present. Now, is it hemolytic? No. Hemolytic anemia is very rarely associated with the fever and all those things. Okay? Now, pattern of the fever is not suggestive of viral and bacterial because, see, a viral fever है तो वो 4 दिन के बाद कम होना चाहिए. बैक्टीरियल फीवर है तो 4 दिन में धीरे धीरे बढ़ना चाहिए. बट यहाँ पे फीवर क्या है? एक ही जैसा है और माइल्ड है. So this is immunological fever. So this is something related to immunological fever. So this is a case of bone marrow disease with developing leukemia. Okay, infiltrative leukemia. So like this, we have seen all the 4 types of anemias in detail. Then we have seen the case discussion related to this. I hope I have taken much more time. Thanks again for the organizers for giving this opportunity. Thank you very much.
Thank you so much, sir, for eye-opener and wonderful session. And I will invite to Dr. Hetal ma'am for next.
सच में बहुत ही बढ़िया सेशन रहा और बहुत सारे एक्सप्लेनेशन के साथ डिस्कशन के साथ और बहुत अच्छे एग्जाम्पल के साथ डॉक्टर श्रीनिधि जी आपने ये विषय को सबके सामने रखा है। मैं समझती हूँ कि सभी स्टूडेंट्स पीजी और यूजी और पीएचडी अध्येता इसमें से अपना ज़रूरी जो बात है कि अपने-अपने ओपीडी के पेशेंट्स में वो ज़रूर लागू करेंगे और मुझे लगता है बहुत सारे लोगों को तो फिर से भी सुनना पड़ेगा, इसमें से मैं भी हूँ कि फिर से एक बार सुनना पड़ेगा और उन तथ्यों को फिर से रिवाइज़ करके क्योंकि मुझे बहुत सारे लोग बताते हैं कि इतना ज़्यादा वंडरफुल और डिस्क्रिप्टिव और ऐसे ज़बरदस्त प्रेज़ेंटेशन होता है कि उसको एक बार और उस प्रेज़ेंटेशन को सुन के और फिर उसको तादाद में करने की कोशिश करते हैं। तो मैं समझती हूँ कि बहुत ही बढ़िया सेशन रहा डॉक्टर साहब और विश्व आयुर्वेद परिषद की ओर से आपका डबल धन्यवाद आज मैं कर रही हूँ क्योंकि आप इमरजेंसी में ही आपने तुरंत ही जैसे ही मैंने आपसे निवेदन किया और आपने तुरंत ही लेक्चर के लिए हाँ बोला। तो डॉक्टर साहब आपका बहुत-बहुत हार्दिक धन्यवाद। जैसे पहले भी जब ऑफलाइन हमारी क्लास होती थी तो आपने इम्यूनिटी और बाल ग्रह और ऐसे बहुत बढ़िया-बढ़िया टॉपिक्स पढ़ाए थे। उसी की तरीके से आज का भी ये लैंडमार्क है कि ज़बरदस्त लेक्चर है और जो आने वाले दिनों में बहुत सारे लोगों को ये उपयोगी रहेगा और कहीं न कहीं वो आयुर्वेद की चिकित्सा को अच्छी तरह से लोगों के बीच में ले जाने के लिए वो फलदायी रहेगा। विश्व आयुर्वेद परिषद की ओर से मैं आपका हार्दिक धन्यवाद करती हूँ डॉक्टर साहब। बहुत-बहुत धन्यवाद।
Thank you very much. Thank you.
हाँ जी, डॉक्टर ममता।
जी, शांति मंत्र के लिए निवेदन करूँगी मैं सभी अनम्यूट होके शांति मंत्र पढ़ें।
ॐ सर्वे
भवन्तु
भवन्तु
सुखिनः
सर्वे सन्तु
सन्तु
निरामया
निरामयाः
सर्वे
सर्वे
भद्राणि
भद्राणि
पश्यन्तु
पश्यन्तु मा
मा
कश्चित्
कश्चित्
दुःखभाग्
दुःखभाग्
भवेत्।
भवेत्।
ॐ शान्तिः शान्तिः शान्तिः। नमो नमः। सभी का हृदय से धन्यवाद। बहुत-बहुत धन्यवाद।